Good morning, everybody, and thank you for coming to Grand Rounds today. We will be ending Pacific Asian and Islander Heritage Month rights with a wonderful presentation this morning by Dr. Mao. And before that, we'll have our usual weekly updates. As always, we'll move on to Dr. Pinsky.
Thanks, Errol, and good morning, everyone. Here is our now familiar epidemiologic curve for the variants that we're seeing in the Stanford patient population. Our test volumes are modest and our positivity rate, fortunately, is very low at the moment. So we have a limited number of positive samples to genotype, which you can see here on panel A on the far right. As has been the case for the last month plus, the most common variant in our population is the B117 UK variant that contains the N501Y mutation, and that continues to be the case over the last week. You may notice the graph is a little bit different than previously. The dates on the bottom are the week ending instead of the week beginning, in order to be more consistent with how the CDC reports their data. You may also notice there was this bump in L452R containing mutation variants. This mutation is associated with the California variant B1 429, but this week we also identified a number of individuals that contained the B1617.2, which is one of the sublineages that was identified in India, and we have not seen a significant additional number of those cases, fortunately. That is my update for this week, and thank you. And again, happy to take any questions in the chat.
Thank you, Dr. Pinsky and Dr. Bowman as well for those weekly updates. We greatly appreciate it. You'll see I'm sharing a picture here, and this is a picture from the CTRU that was set up, the tent that was set up on campus earlier this past year when the pandemic began. And I'm particularly happy today to be able to announce that we are launching our annual report. And our annual report is our sixth annual report that we've been doing over the years. And naturally, we will be sharing a lot of stories about the pandemic and our response to it. That's been a big theme of what we've been covering, along with many other important topics, such as our issues of inequity, are another theme we'll be sharing. But in this annual report, and you'll be seeing that email coming out to you guys any moment now, or it may have just come out, we'll be talking about all the stories of things that were going on with faculty, with staff, and how the staff played a very important role, oftentimes behind the scenes, working from home at times as well. We'll be sharing stories from the VA to Valley Care. We'll be sharing stories of our house staff. This is a picture of Dr. Layla Beach from cardiology, who created this amazing video to help recruitment, which ended up leading to multiple other videos from different divisions to increase recruitment when it was very crucial to do so, despite being in the pandemic. We also want to remember that in this annual report, we had a lot of non-COVID related medicine going on, from clinical medicine to team science, as well as a lot of personal stories. We have a story from Dr. Tian Zhang from hematology, who was able to share this amazing story of dealing with challenges with her son and medical breakthroughs that helped him recover, to meet the Beckers. Lauren and Nielsen Fernandez Becker, our power couple from GI. Both Dr. Zhang's family and the Beckers won't have to worry about holiday photos this year. We got you covered. We'll send you all the photos later today. But our annual report theme this year is meeting the moment. We thought that was an appropriate term because we essentially did meet the moment, and we did it all together. And I want to thank everybody who was part of this, from all our leadership who helped us come up with the stories. We have over 27 stories from all the different divisions. We tried to make sure we were covering every aspect of diversity through all aspects of every aspect of our faculty, to make sure we were well represented. And this is just the start. This is something that, as our annual report is just one aspect of our communications that we do. And I want to say our goal is to try to capture as much as we can, but there was no way we came close to capturing all the amazing work that's happening throughout our department and our community. And our goal is to keep doing that. So please give us feedback on how we can make sure we're acknowledging and recognizing everybody in our department as we move throughout the months and years ahead. So please do let us know. We will be having a celebration tomorrow for 15 minutes. We usually had one in person, but this year we'll do it remotely. We'll be sending an email out to anybody who was part of this. If you didn't get that email, please let me know. I'll make sure you get it. And if you want to join for whatever reason, please do join. I want to thank Lindsay Baker and Cassie. Lindsay and Cassie have been a huge part of our communications role, and many of you have interacted with them regularly if you ever emailed me or we were doing any sort of story on you. So they're a huge part. Lindsay and Cassie, thank you so much. Jack Zhang, who's been putting together the whole website, has done an amazing job of this. And sorry, I didn't show the pictures we're showing up here, but this is the slides here. And Jack did an amazing job. Thank you so much for that. And as well as multiple people, Penny Hodgkin, who's worked with Bob Harrington for over 20 years from the DCRI and Duke. She's been a big part of this, and a number of other people will be acknowledging tomorrow. I also want to thank Kathy Garzio, as well as Bob Harrington. Dr. Harrington is essentially behind all the great things, all the things that we do that end up working out well are his ideas that come from tweets on websites to doing this annual report. These ideas come from him. And so thank you, Dr. Harrington, for all the support. I'll stop there. And I'm going to now just mention that next week we have the Pride study with Drs. Lund and Obadin Malaver. And the week after that, we'll be talking about COVID variants. I especially thank for Latha, Dr. Planiapen, who is going to be introducing our speaker today, Dr. Mao. And Dr. Planiapen has been extremely helpful organizing this. And thank you so much for introducing our speaker today, as well as emceeing the rest of this. I'll turn it over to you.
Thank you, Dr. Olsdalga. I want to thank Dr. Olsdalga for inviting me to moderate today. I want to acknowledge Drs. Harrington and Olsdalga for regularly recognizing in our Medicine Grand Round series Stanford's unique strengths and diversity, and acknowledging the unique health risks and differences in the populations we serve. Studying these diverse populations will enable us to achieve our goal of precision health for all. It is my pleasure and honor to introduce to you today Dr. Marjorie Mao. Dr. Marjorie Mao is the Myron Thompson Chair of Native Hawaiian Health Research and is professor at the John Burns School of Medicine in the Department of Native Hawaiian Health. Dr. Mao is the first Native Hawaiian woman endocrinologist and the inaugural chair of the Department of Native Hawaiian Health, the only clinical department in an accredited medical school dedicated to Indigenous health in the United States. Dr. Mao has an illustrious career as an NIH-funded investigator since 1992 at the University of Hawaii in Mānoa. Her scientific career has been dedicated to advancing the science of diabetes and cardiometabolic health disparities among Native Hawaiians, Pacific Islanders, and other Indigenous populations in the Pacific region. She has published and contributed to more than 100 papers and has mentored dozens of emerging scientists from diverse racial, ethnic backgrounds and scientific disciplines. Dr. Mao has been recognized by her peers over the years. In 2010, Dr. Mao became the only Native Hawaiian scientist selected as one of 14 supported biomedical faces of science, which highlights role model scientists of diverse backgrounds. In 2015, she became the first woman physician in Hawaii to be awarded mastership in the American College of Physicians. In 2017, she was inducted into the Fellowship of the Royal College of Physicians in London, which is an extremely rare honor. Today, Dr. Mao remains actively funded by multiple NIH research awards, R01s, U01s, U54s, and continues to work collaboratively across clinical departments at the medical school, as well as across the Mānoa campus with colleagues from nursing, social work, psychology, tropical medicine, and public health, to name a few. Dr. Mao also works in Alaska, where she maintains personal and work relationships in Anchorage. In Hawaii, Dr. Mao provides community service to the Polynesian Voyaging Society, the Ohana Wa'a family of voyaging canoes, and the Friends of Hokulea and Hawaii Loa. I have read and admired Dr. Mao's work for decades and had the pleasure of meeting her for the first time this year virtually in the National Institutes of Health Trans Institute workshop on Asian American, Native Hawaiian, and Pacific Islander health. I am impressed by the breadth and depth of her work in Native Hawaiian and Pacific Islander populations, and I was delighted that she accepted our invitation to join us for the finale of our excellent Grand Rounds programming for AAPI Heritage Month in May. It is 5 a.m. her time in Hawaii, so please join me in giving her a rousing welcome to our virtual stage.
Thank you so much, Latha, and everyone over in Northern California. My son lives in California, one of them anyway. So I'm really happy to participate in your Grand Rounds. And I don't know if everybody can hear me, because it's hard to hear with these things on, but anyhow, let me see if I can share my screen. And
you sound great.
Okay, thank you. Okay, let's see. Can you see my screen? Well, I can't see you folks, so someone has to give me an audio on that.
Yes, we can see them. Thank you.
Okay, thank you. Okay, so I have no disclosures, no conflicts of interest to disclose to the group here. And I'm really happy to be invited to this large Department of Medicine Grand Rounds. So today, these are the three things that I'd like to get done in the time that I've allotted here. And I'm going to try to give you sort of a TED Talk version of the kind of work that we've done over the last 20 some odd years regarding cardiometabolic health and disease among Native Hawaiian and Pacific Islanders. But my underlying goal really is to improve the Olelo Hawaii language skills of every single participant by the end of this 35-minute talk. So the people of Oceania, what I like to call Na Kanaka Oiwi, is located here on this map, which focuses on the Pacific Ocean. And this is what we would term the Polynesian Triangle, anchored by the state of Hawaii, Aotearoa or New Zealand, and Rapa Nui or Easter Island. And it sits within the region of Oceania, which is included here. Some of you may know this as the Ring of Fire. This is the all the border countries surrounding the Pacific Ocean, the largest ocean in the world. And it happens to be the place where we're planning our next ocean voyage in 2022 to 2029. It'll take us 7 years. And it's called Moana Nui A'akea, and it'll circumnavigate the Pacific. So we'll be coming to California, by the way. So I'm going to talk a little bit in this 12-minute section about who we are. It's our mo'oku auhau, which is our genealogy, and how who we are shapes our health and well-being. So a few useful terms. February was Olelo Hawaii month in Hawaii, which is the Hawaiian language. It's an official language of the state of Hawaii along with English. And these are the words that you may see during this presentation, highlighted in red. The black ones are ones that I'm pretty sure you're familiar with already. So what has the science revealed about Polynesian migration? This is a study that used 157 complete mitochondrial DNA genomes to identify the Polynesian motif. And from this data, we've learned that Polynesians' distant ancestors were from mainland Southeast Asia. Here, I don't know if you can see my arrow, but anyhow. And they 10 to 12,000 years ago left to the islands of Southeast Asia here, which includes the Philippines, Indonesia, Melanesia, and Borneo. They voyaged to near Oceania, to the Bismarck Islands about 6,000 years ago, creating a voyaging corridor until populating remote Oceania less than 5,000 years ago. So remote Oceania would include Polynesia, which I'm including Hawaii in, as well as Micronesia, Melanesia, Fiji, and Vanuatu. How was the Polynesian Triangle, remote Oceania, populated? This is a nice paper, a couple of papers actually, that have hypothesized how this has happened over time. And the best data so far seems to suggest that the populations started somewhere here near Samoa and Tonga, stayed there for about 500 years, and then about 1025 to 1121 AD, migrated into the Society Islands here. And then about 1200 to 1290 AD, had an expansion into this yellow area, which you will now recognize is the Polynesian Triangle. This is based on, again, mitochondrial DNA that's very useful for tracking migration of populations. This would be then the peopling of the Polynesian Triangle. And the theory goes, based on this data, that it was a single expansion of a slow boat, island hopping type of migration. And this happened about 700, 800 years ago. The peopling of remote Oceania, Kapa'aina, about 1,300 years ago, there was a single strong expansion shown here in this paper back in 2012. So based on this information and what we have learned from our own cultural myths, legends, and stories, is that who we are is Na Kanaka Oiwi. So Na is the plural, Kanaka is humans, and Oiwi is the bones, where we feel the Polynesian and Pacific Islander people draw their origin. And within a traditional ecological knowledge context, these are the types of things, concepts or constructs that people from Oceania and including Native Hawaiians most identify with. In terms of the historical socio-political context, it's important to recognize that 1778, the birth of the United States of America, was happening. This is reported to be the number of Native Hawaiians that lived in Hawaii. And about the 1700s, Europeans arrived first, followed by Americans. And then in 1893, illegally overthrew the Hawaiian government. And then over the years, there were a series of really systematic ways of eliminating how the indigenous population was able to participate in any political determination. And then we were illegally annexed, and then in 1959 became a state. And today, ongoing, there's still quite a bit of immigration to Hawaii. These are the major racial ethnic groups in Hawaii, and you can see clearly that there is no one dominant race and ethnic group in Hawaii. So in that regard, we're very distinct from most of the other 49 states in the US. In today's context, as I mentioned, Na Kanaka Oiwi draw their ancestral origins to Polynesia and Oceania, not to North America. And all Native Hawaiians today, because of the story that I just told you, have an ancestor who came to Hawaii on a canoe, on a va'a kaulua. When you think about that, it then makes sense why Native Hawaiians and Pacific Islanders, who are of the same genealogy, really gravitate towards the ocean. because that's our origins. And the first inhabitants of the Hawaiian archipelago, the furthest north of the Oceania populations, occurred about 1,200 years ago, and intentionally and repeatedly voyaged to Hawaii and arrived already with an existing system of indigenous ways of knowing. And I'll give you some examples such as wayfinding. Today, Kanaka Oiwi have been apologized by the United States for the illegal overthrow of the monarchy. The first apology occurred by Grover Cleveland in 1893, and then Clinton in 1993. Prior to the 1970s, most were unaware, including myself, of their ancestral origins, and really had lived through unspoken historical and cultural trauma. For example, the Hawaiian language was banned to be spoken, cultural practices were suppressed and eliminated, and places, legendary ancestral places of importance, wahipana, were destroyed or cemented over. So institutional racism remains and coexists with the growing prominence of Native Hawaiian resilience and resourcefulness and empowerment today. So my question to all of you is, how many have visited Hawaii? And I have a very short poll that Earl is putting up. Thank you very much. And you can take your time in answering them, and we'll have the answers at the end of the talk. I don't know if I can move forward.
Yes, you can go ahead.
Okay. Oops, I feel like I'm stuck. There we go. So there's a few interesting facts that you might have overlooked while visiting. I'm sure most of you have visited Hawaii. I mentioned the WHO of the state's population. What is the percentage who identify as Kanaka Oiwi or Native Hawaiian? That's about 20% of Hawaii's population identifies Native Hawaiian. Where do most Kanaka Oiwi live in Hawaii? Urban, rural, suburban? And the answer would be rural. Most Native Hawaiians live in a rural setting. And the island and the region with the highest percentage would be Molokai. 50% of the residents that live on Molokai are of Native Hawaiian ancestry. And name at least one wahipana or ancestral place of importance on Oahu. And I'll get to that when we get to our poll questions. And then the bonus question, gosh, I don't know if you guys see that, is here. Can anyone, you probably recognize the Golden Gate Bridge, but in the foreground, there's a Va'akaulua, and it's, of course, the question is, name its corresponding navigational star. And you can write that in the chat. If you answered Hokulea, you're correct. This is Hokulea on its one of its many voyages to California. It's also known as Arcturus. It's a navigational star. It's the zenith star over Hawaii. And this is one of many stars that our navigators use to wayfind. Okay, I'm gonna move over, and Earl, is it possible to move the quick poll? I don't know how it looks on your screen, but it looks like it's right over the center, but.
Sure. I will end it.
Everybody's memorized the questions. Okay, super good. So I wanna start off with talking about cardiometabolic health in Native Hawaiians and Pacific Islanders by first talking about how it started a little bit. It really took hold in 1985 with the Aolamau report, which is the first comprehensive study of Native Hawaiian health needs and recommendations. And this is data that was drawn from public health records and various other surveys that were being done at the time. And The Aolama report resulted in the Native Hawaiian Healthcare Improvement Act of 1988. And Congress passed this Health and Care Improvement Act, and it was signed by the President of the United States at that time. And it was a bill to improve the health status of Native Hawaiians. In 1991, 3 years later, the Native Hawaiian Health Research Project was awarded by NIH to a group of scientists in Hawaii at the University of Hawaii. And it was the first epidemiological study of Native Hawaiian adults on diabetes and cardiovascular risk. And I was fortunate to come home the year after, and so I didn't have to write the grant, but I got to be part of it. And this is the data that came out of the Native Hawaiian Health Research Project as a historical marker of how far we've come in terms of diabetes and understanding the prevalence of diabetes and impaired glucose tolerance in Native Hawaiian adults. And this data from Hawaii and Kauai is from the Native Hawaiian Health Research Project. And this is data from Molokai carried out by Dr. Emmett Aluli. And you can see that the prevalence in women and men and overall are very, very similar, even though the methodology was slightly different. And in the Native Hawaiian Health Research Project, because we were doing 2-hour oral glucose tolerance tests, we also were able to estimate impaired glucose tolerance at that time. So combined, there was about 1 in 3 Native Hawaiian adults back in 1992 that was at risk or had diabetes at that time. Over time, the prevalence of diabetes and prediabetes, now a new term introduced recently in Native Hawaiians and Pacific Islanders, has only increased. This is the last 50 years. Back in 1992, I had read every single paper on diabetes in Native Hawaiians, and this is it. An N of 364. This is data from Molokai, about 257 Native Hawaiians. You can see the prevalence of diabetes is 5, 12, 20.5, and now 27.7. And more importantly, how prediabetes or risk for diabetes has also increased over the years, such that now prediabetes has surpassed the percentage of Native Hawaiians and Pacific Islanders that actually have diabetes. So this is truly a problem. And globally, I always think about this as the other global pandemic in the Pacific. This is data from the International Diabetes Federation World Atlas. And you can see that it's predicted that there'll be a 51% increase in diabetes in the world by 2045. I want to focus on the Western Pacific, which is a single area that has the highest number of diabetic individuals predicted in 2045, but also measured in 2019. And this is expected to increase by 30% by 2045. But what's really striking is the need for prevention. As you can see across the IDF regions, the Western Pacific is predicted to, it has the most individuals with impaired glucose tolerance. 1 in 3 adults are at risk of developing type 2 diabetes in this region of the world. So what is cardiometabolic health? If you look throughout the literature, there's a lot of different definitions. It's the cardiometabolic syndrome, disease, dysfunction, and disorders. This is one definition by the American College of Cardiology as a clustering of these risk factors that all of you are very familiar with. Cardiometabolic syndrome is recognized as a disease entity by both the World Health Organization as well as the American Society of Endocrinology. And health and healthcare disparities is been redefined many times. This is a recent one by the Kaiser Family Foundation. And it talks about health as well as healthcare between groups that stem from broader inequities. So cardiometabolic health disparities arguably is one of the most important threats to the health and well-being of Native Hawaiians and Pacific Islanders. And the reason I say that comes from this data, a study by Dr. Emmett Aluli on the all-cause and CVD mortality in Native Hawaiians. It's the single largest cardiovascular disease longitudinal outcome study of 855 individuals. That doesn't sound like a whole lot, but given the number, the denominator, it's actually a pretty good number. And these are all on Molokai. And what you can see is the men and women all-cause mortality. And in this study that we published a while back in 2010, the all-cause mortality was similar to the US general population. And that was surprisingly low to us after 12 years of follow-up. 55% of the deaths were cardiovascular disease and 23% were cancer. And the risk factors associated with CVD mortality was age over 50, diabetes, hypertension, and LDL over 130. And when we looked separately at individuals with diabetes or no diabetes, clearly you can see that most of the CVD mortality is occurring in people with diabetes. So I want to share with you our website. This is the Center for Native and Pacific Health Disparities. I have our website location here. And on the website, you can go through our publications and you can see many of these publications that I'll share with you today in an overview format. Our center focuses on cardiometabolic health and health disparities. And what I've done is try to highlight the diabetes research that's been completed aimed at improving clinical outcomes in Native Hawaiians and Pacific Islanders. There's this paper on the Native Hawaiian diabetes intervention. We've looked at epidemiological and clinical factors associated with chronic kidney disease among Asians and Native Hawaiians, and factors associated with poor glycemic control or wide glycemic variability among diabetes patients, and the comparison of potentially preventable hospitalizations among the major ethnic groups in Hawaii. And I'll summarize this in a slide or two. We've also done a number of different studies looking at obesity, and in particular, diabetes prevention and obesity research aimed at improving health disparities. We have a long-running study called the Piliohana Project, which is the translation of the diabetes prevention program for Native Hawaiian and Pacific Islander communities. We've also looked at what are some of the variables that predict weight loss in Native Hawaiians and other Pacific Islanders. And I have conducted a number of different trials and effectiveness trials looking at how to take the modified DPP, the PILI program, into our Native Hawaiian communities by teaching the Native Hawaiian communities how to implement them. We've also conducted and focused on CVD research aimed at improving risk reduction of CVD outcomes. We've looked at many of the social determinants of health in this population and the other ethnic populations at risk. In particular, Filipino population here in Hawaii have numbers that parallel those that we see in Native Hawaiian and Pacific Islanders. We've looked at racism. We've looked at cultural dance, hula. I should have put that in a poll. How it improves hypertension management. And we have produced an assessment and priorities for health and well-being in Native Hawaiians and other Pacific peoples. It's a wonderful resource for individuals to look at the work in Native Hawaiians and Pacific Islanders. We get a lot of students who are interested in some of this data, and this is a sort of a one-stop publication where you can get a lot of updated information. And we've also done a lot of work on heart failure and stroke aimed at improving health disparities. So my colleague, Kazuma Nakagawa, a neurointensivist, have looked specifically at intracerebral hemorrhage, as well as ischemic stroke patients in Hawaii, looking at racial and ethnic disparities. And then we've also looked at heart failure, looking at the Pacific Islanders' perspectives on heart failure management, During the course of our study, found the impact of methamphetamine on the methamphetamine use and heart failure among Native Hawaiians and Pacific Island people, and then actually conducted the largest cardiovascular clinical trial called the Malama Pu'uwai Caring for Heart study, showing how an educational program improves rehospitalization and CVD mortality. So to summarize what I just went through, a couple decades of research that we've done in collaboration with our communities under the center. This is some of the take-home messages, if you will. First of all, I want to point out that if you want to follow up on any of those publications and more, this center has actually really extended our scientific understanding of health and healthcare disparities in Native Hawaiian Pacific Islanders, including Filipinos, with over 175 peer-reviewed publications. What we've discovered is that cardiometabolic disease, whether you're talking stroke, cardiovascular disease, hypertension, diabetes, obesity, chronic kidney disease, we have data in many of the papers on our website that occurs 10 to 15 years earlier than whites. So particularly in cardiomyopathy, a disease that normally occurs in people in their 60s and 70s, occurs in 40s and 50s in Native Hawaiians. Diabetes is indeed a major cardiovascular risk factor for CVD outcomes, presented by Dr. Aluli's data over 12 years of follow-up. Obesity and overweight affects more than 85% of the Native Hawaiian Pacific Islander population. And some wonderful articles that I didn't show because of space and time by Dr. Mascarenek at the MEC, from the MEC data, shows that the impact of excess weight depends on the racial ethnic admixture. In particular, if you're Asian Native Hawaiian Pacific Islander, you have a particularly high risk of outcomes. So I refer you to those papers as well. Dr. Mascarenek's the wonderful scientist that we work with. And then CVD, stroke, cardiomyopathy is the #1 cause for mortality, and it surpasses cancer, at least in the Molokai heart study, which we believe is somewhat generalizable to the rest of the population we see in Hawaii. And most deaths due to cardiovascular atherosclerotic disease occurs in Native Hawaiians with diabetes. And a final point that you'll see on our website is that community engagement has been critical, fundamental, really, to advancing the science. Science careers have actually advanced in our Native Hawaiian communities. There have been many of our Native Hawaiian partners who have actually gone on to get their degrees, their doctoral degrees, master's degree, graduate degrees, as a result of working with us. And our lives have also been enriched by understanding the perspective of the community in the research that we do in partnership with them. And I refer you to a online educational program called Community 101 for Researchers. If you have a desire to work in Native Hawaiian Pacific Islander communities doing research, you may find this particularly helpful. And anyone can go on, register, and there's a short quiz and certificate that results after you're done with the program. So I'm particularly proud to say that back in 2014, when Director Yvonne Maddox was the acting director of NIMHD, she spoke at this conference and at a time when we actually traveled. And I was so proud to see that we actually needed our work at the center and others in Hawaii actually was on the NIH map, that they finally recognized and publicized the burden of obesity and diabetes among Native Hawaiians and other Pacific peoples, along with many of the other minority populations, such as the Jackson Heart Study and prostate cancer in African American women and HIV, dementia in Hispanic women, and so on. So I really felt like we had pushed forward on this, and we really could not have done it without our communities communities of grassroots communities. Here is our ULU Network. It's made up of 70 plus organizations across the state of Hawaii here, Kapa'aina, as well as a site here in Southern California. And all of these organizations serve Native Hawaiian Pacific Islander people, maybe not exclusively, but they serve them. And so they are all part of our ULU network under the center. And I can't help but mention all the colleagues that we have worked with in the Department of Native Hawaiian Health. This is a hub and spoke diagram showing every square is a funded grant, four-sided geometric figure is a grant, every four-sided one, and every round dot is an investigator. All the red ones come from the Department of Native Hawaiian Health, but every other color is coming from somewhere else. So you can see that one of our characteristic features is that we like partnering with other people. So now I'm going to move on to navigating the future in 2022. And what better way to navigate than through wayfinding? This is the bow over Hokulea on our way to Micronesia. And the Naya, the dolphin. I don't think I had that on my glossary of Hawaiian terms. I'll have to add that. Okay, so Native Hawaiian Pacific Islanders is all about diversity. And as you all probably know, that the heterogeneity within in this racial ethnic group is very diverse. And when I talk about diversity, I'm really talking about the scientists as well as the science. So we're embarking on supporting omics research, discoveries in cell and molecular mechanisms of health disparities, being led by our Native Hawaiian Pacific Islander scientists. And I'll share a little bit about that. We're moving beyond cultural adaptation, which we've done for 15, 20 years now, myself in particular, as well as others, for intervention studies, and embedding what we call ancestral knowledge systems or traditional ecological knowledge into the work that we design with communities. And then we remain very community-centric, using our place-based knowledge, and Native Hawaiian and Pacific Islander communities are hungry for DIY, do it yourself. They want to do it themselves. And that's how we believe it'll be sustainable over time. So this is some new genomics and epigenomics research being led by Native Hawaiian Pacific Islander scientists in this field. When I started a while back, none of these individuals, I think they were in high school or something. Anyway, they are doing some outstanding work. This is one of the papers from the New England Journal of Medicine by Keolu Fox, looking at he's a geneticist and anthropology scientist at UCSD, looking at the All of Us research program. And then Dr. Leah Dowsett is another geneticist working here in Hawaii in our Kapilani hospital, who's also looking at genetics as it relates to different syndromes that we see in the pediatric population. We also have a Native Hawaiian epigenomic scientist. The first one, Dr. Alika Mauna Kea, has published some interesting work on the implications of developing Indigenous science in the field of epigenetic research. Recently published a paper on DNA methylomic analyses looking at epigenetic biomarkers, immunoepigenetic biomarkers of insulin resistance in monocytes. And this is a recent paper that many of you perhaps in the field know about, looking at the impact of global and local Polynesian genetic ancestry on complex traits in Native Hawaiians, coming out of the Cancer Research Center of Hawaii, the MEC cohort. And Annette Lum Jones is actually a Native Hawaiian who's one of the co-authors. So we're particularly proud of the idea that we're looking at other mechanisms, cell and molecular mechanisms of our health disparities, and there are Native Hawaiians in the mix. Some of our intervention research is in process. It's actually designed by ancestral knowledge as opposed to the other way around. And this is the Kahola project. This is a paper on the protocol for randomized control trial. And the actual results of the randomized control trial are in review right now, so I can't share them with you. This is being led by Keaweai Moku Kaholakula and Mapuana De Silva, who's Kuma Hula. She's an expert in hula, the practice of hula, who is one of our well-respected kumahulas here in Hawaii. And I'm currently working on the idea of voyaging in health. This is our qualitative study. Again, it's under review, so I can't really share the data with you right now about perspectives and insights from the medical officers during our worldwide voyage. So this is my final slide. Maruru, mahalo piha, merci beaucoup. We'll give you a clue to where this is. This is in Tahiti. And I want to thank all these organizations who have helped support the work of the center and myself in particular. These are some of my colleagues currently, but there are many more that I could not put on this slide. And so I'm happy to take questions, and hopefully Earl can give us the results of the poll. Thank you. Oh, here we go. So I hope all of you can see this. I can see it on one of my screens, but 46% have been to Hawaii 1 to 3 times, and about 15% have been there 3 to 10 times, and 6% have been too many to remember. So more than 50% have been to Hawaii, for sure. It's surprising to me. You're just one state away from us, you realize. And during your most recent visit, I would say that it's pretty evenly split between Maui and Oahu and Big Island, following up second as a close second. And then the third question, where is that, Earl?
Just scroll down.
Oh, shucks. I closed it thinking that it was behind it. Could you put that back up?
I might read it out loud to you. I identify the only Native Hawaiian sovereign land in Hawaii. And this question was evenly split, almost 20 to 30% for each answer. And the correct answer is, well, is the correct answer Iolani Palas?
No.
Oh, it's just the first one then is colored red, but, or no, it's the one that had the most responses. But what is the correct answer, Dr. Mel?
Yeah, the correct answer. I'm sorry to punk you so early in the morning, but it's just really interesting for me to know. So the only piece of sovereign land is Mānoa. And Mānoa is on Oahu. It's on Nu'uanu Avenue. And it's the resting place of most of our Hawaiian royalty. So King Kalakaua, Queen Liliuokalani, Bernice Pauahi Bishop are all buried at Mānoa.
Thank you, Dr. Mel.
That's thank you for helping me understand where people know about this. So
Dr. Mao, we have many questions and we only have 4 minutes. So if you don't mind, I'm going to group some of them, and we can send you some of the questions afterwards if you have Sure. Some time to answer them. So the first 2 questions I'm going to group, they're on diet. So Dr. Croak asks, is there increased uptake of the Waianae diet, and has it been studied as to its impact on Native Hawaiian health? And Thomas Burns asks, is there anything about the Native Hawaiian diet that makes them more susceptible to obesity?
Yeah, those are really great questions. There's been so much good work in nutrition from the Cancer Research Center. Some scientists who actually even preceded me coming home, looking at the Waianae diet, which for those who don't know is a very high complex carbohydrate diet, minimal amount of protein, high fiber diet, and very low in processed carbohydrates. It was popularized by Dr. Shintani, who is a physician here in Hawaii, and there are a couple of papers by Dr. Emmett Aluli, because he tried the Moloka'i heart diet, which is basically a Native Hawaiian diet here. And I think I could summarize what we know about the traditional Hawaiian diet is that the composition is a good composition, nutritionally, it's basically a vegetarian type diet with a little bit of protein, and it works well. I think the problem that we have observed on the traditional Hawaiian diet is that it can be very expensive. It's based on the use of kalo, taro, and taro is very expensive. So people have to substitute what would give you the same nutritional value for what kalo would give you. And so as a result, because of the access for taro, it's very hard to sustain over time. And I think that's probably the biggest challenge to the Waianae diet or to the traditional Hawaiian diet or Moloka'i heart diet. Those are all the same synonyms. And is there anything about the diet that puts you at increased risk for obesity? I don't believe so. Obesity and body composition is really interesting in our populations. Anybody out there who's interested in obesity research, this is a really cool place because we have Asians who have or admixed with Native Hawaiians and Pacific Islanders, myself included. And it's an interesting idea about that. But there are a lot of Native Hawaiians that have a high BMI and do not have diabetes.
Mm-hmm.
Perhaps eventually they will because of age, but there's the Native Hawaiian diet is a healthy diet.
Mm-hmm. So quite a lot of paradoxes to study there, it seems.
Yes.
So we are at the top of the hour, so I'm going to invite those who need to get on to 9 o'clock to leave and to thank Dr. Mao for getting up so early Hawaii time to share your knowledge with us. We are extremely grateful. There are quite a few other questions, and I want to give a shout out to Cheryl Albright, who's actually a graduate of the Stanford Prevention Research Center and was a faculty member here for some time. I see she's your colleague. And I think Dr. Harrington might like to say something.
Well, first, not only on behalf of Stanford, but I would be remiss if I didn't say on behalf of the American Heart Association, thanks for all the work that you do, because this is critical to our understanding of coronary disease. And I hope you'll indulge me to ask a question. One of the things that strikes me about diabetes, and particularly where it's really epidemic in some areas of the world, as you've pointed out, is this intersection of tobacco use and diabetes and the additive effect it has on atherosclerotic acceleration. Can you comment on that in the Native Hawaiian population?
Yes, so it's somewhat interesting that in the Native Hawaiian population, the smoking rates of tobacco are not that high as compared to American Indian, my American Indian population colleagues. We actually I haven't really looked very carefully at the intersection between smoking and diabetes as additive or maybe exponentially additive to coronary artery disease or cardiovascular disease. I think that's a really interesting suggestion. Marijuana has always been a commodity here in Hawaii. And in Micronesia, a lot of betel nut consumption is we see a bit of that. So I think that there's, this is the substrate for a really great study to look at that, because I think that you can see across the spectrum different smoking materials, substrates, as well as different populations. I think that's a great study. I'm not, as I'm thinking about it, I'll have to ask my Cancer Research Center colleagues of whether they've specifically looked at that.
Great, thank you.
Thank you for having me.
Thank you, Dr. Ma. If you don't mind answering just one last question.
Sure.
The audience asked for, there was a certificate mentioned for API research, perhaps offered at your institution, and they would like some information about that. And if you are able to tell the audience, I think that would be a nice way to close.
Oh, yes. So I put the link on my talk on the community, and it's a certificate. As you go through the educational modules, there's a certificate of completion on, it's called Community 101 for researchers. And it's an online program that you go through to learn about how to conduct research with communities, Native Hawaiian Pacific Islander communities. And I know there's lots and lots of Native Hawaiian Pacific Islander populations in California. I think you folks, we're 1 and 2. Hawaii and California is 1 and 2 in terms of the Native Hawaiian Pacific Islander population. So I would refer you to that particular slide. I know we're going to have my slides there, but if you go to our center website, just put in Center for Native and Pacific Health Disparities Research. And on the website, it'll say Community 101 for researchers in the little box on the right. And you click on that and it'll take you to the link.
Thank you, Dr. Mao, for all the wonderful work that you're doing. And we're honored that you were able to join us to be the finale for AAPI Heritage Month. Thank you.
You're welcome. My pleasure.